All right. Hello, everyone. Welcome to our first webinar. If everything goes well, we'll probably be doing more webinars like this. Once we finish this live webinar, we will post this on our group page with LPP, Let's Put Out the Fire YouTube channel. First, I want to thank my technical assistant, Edgar. I could probably not do without his help. Thanks, Edgar. So I have known Dr. Donovan almost 17 plus years. From the Sunnybrook Hospital, he did my first biopsy and treatment. And I must tell you that I have never seen a nice, professional, respectful, compassionate, dedicated dermatologist through my journey with LPP. Again, thank you for your time and accepting my invitation, Doctor. Dr. Donovan is a US and Canadian board certified dermatologist specializing in treatment of hair loss. He has focused exclusively on hair loss from beginning of his dermatology career. Today, Dr. Donovan will do a short presentation, and then we will go into Q&A. So without a further ado, welcome to webinar, Dr. Jeff Donovan. Welcome, Doctor. Stage is yours.
Thanks so much. Thanks so much, Hatcho. It's really wonderful to be here, and congratulations on the LPP Let's Put Out a Fire group. It really has helped so many people, and it's wonderful to see it. It's wonderful to see it growing, and it's great to be part.
Thank you.
I appreciate this kind invitation. I've been asked to, oops. Hatcho, it says that screen sharing has been disabled. So it's saying that I can't share my screen.
Oh, why is that? I don't know.
It must be something in your settings.
Just give me 1 second. Sorry. Yeah, you're not, should I just invite you again, maybe?
We could try that. I think something in your settings is not allowing screen sharing for your participants.
I did that actually. Hold on a second. Hello, Edgar. Hello, Edgar. He just fell off the...
Yeah, so I can help with this. This is the same problem that you had with me.
Okay.
You just have to click on, in your Zoom, click on the security button. There's a button for security, and then allow participants to share screen.
Okay, security is with the more? No.
It's like a shield button, I think. Maybe it's more, yeah.
Oh, security, got him right here. And share a screen. No, sorry. Is it?
Allow participants to share screen.
Okay, there you go. You're on, Doctor.
Hey, great.
Sorry,
it works like a charm. So,
sorry.
Can you see this okay, Hatcho?
Yes, everything looks good. I hope everybody can see it.
Great. Well, thanks again. I've been asked to speak for 10-15 minutes about some of the latest updates in lichen planopilaris, FFA, and I'd like to review with you 4 really very interesting studies that have been recently published, which give us some new insights into these conditions and some future directions where research may lead. And so let's take a look at these. The first I'd like to review is, what are the medical conditions that seem to be associated with LPP? So if you have LPP, what are the conditions we're learning might be increased? How common is LPP? This has been a great mystery for many years. How common is this? 1 in a million? 1 in 1,000? 1 in 100? Well, how common is it? We're getting some numbers, and I think this is really important. We'll take a look at a very important drug. Many people on the webinar are familiar with hydroxychloroquine or Plaquenil, and we'll take a look at a very important study which makes us feel a little bit at ease, because the eye side effects seem to be a lot less common than we once imagined. And then we'll take a look at the concept of allergy in patients with LPP. Are patients with LPP more likely to have allergies to their shampoos, to their conditioners, to things they put on their scalp? The answer is probably yes, and we'll take a look at this study. So let's get going. What medical conditions are more common in LPP? a really nice study last year set out to look at this. And there's these large databases that are developing now where people with various medical conditions are putting their medical information into it. And one of these big databases is called the All of Us database. And so you're going to be hearing a lot about this. And so these researchers looked at the All of Us database for LPP patients, and they tried to figure out what conditions are increased. And what inspired them was this study in 2021 by Connick and colleagues. And what Connick and colleagues did in 2021 is they compared the diseases in 3,000 LPP patients with 63 million people that didn't have LPP. And they asked the question, what conditions are more common in LPP patients than the rest of the world? And it was discovered, brand new information, that patients with LPP are more likely to have high cholesterol, high blood pressure, obesity, diabetes, and maybe even slight increased risk of various heart diseases. And so this was really important information because this kind of information was not available before this. And so Dr. Joshi and colleagues last year dove into this database called the All of Us database and found that there are certain conditions that seem to be increased in LPP. Now, their study wasn't really big, but it nevertheless was a pretty good study. And it compared LPP and FFA together, so it wasn't separate, but LPP and FFA, and it was discovered that patients with LPP have an increased risk for psoriasis, eczema, melanoma, certain types of skin cancers, rosacea, maybe even inflammatory bowel disease, lupus, heart disease, insomnia. And so this is really important because it provides guidance that patients that come into the hair clinic, it's certainly very important for us to be asking as physicians about how's your itching, how's your burning, how's your shedding, how's your hair loss, how's your eyebrows, how's your eyelashes. But I think we need to remember that there's a whole other body present, and we need to be thinking about these other things. We need to be thinking about, how's your blood pressure, by the way? Has anybody ever checked it? Does anybody ever do a skin examination in you from head to toe? No, I've never had that done. Well, maybe you should. So these are really important studies because they remind us that there are certain diseases that may be increased with LPP. Doesn't mean everyone gets them, but it means they're slightly increased, and it means that we need to be thinking about it. And again, this study had LPP and FFA together, so they weren't separate, and that will be an important question in the future. But how common is LPP? That's the next question I'd like to review with you. It's been kind of a mystery. And my personal view has always been that LPP is pretty common. And I think there are a lot of people in the world that never find out ever in their life they have LPP. They're told that they have dandruff, they're told they have itching, they're told they have, eczema, something. But how common is LPP really? Well, these same authors dove into the All of Us database. So they went back to the same database again and tried to dig out some useful information. And what they found is that in people 65 to 75, probably 1 in 1,000 people have LPP. That's pretty incredible. That's pretty high. And I really think that's in keeping with what the number is. Prior estimates suggested that maybe it's 1 in 6,000. Those prior studies years ago, the first thing I thought when I saw those numbers is it's much higher than that. I'm so glad we have those numbers because we have never been able to figure it out before, but we need better data because I know somehow we're going to get that number down. And this study got the number down to about 1 in 1,000 in people over 65. And in younger people, the chances are a little lower, 1 in 2,000 or 1 in 1,850. But you can see that LPP is pretty common. And so it's a lot more common than we realized. Of course, it's still less common than androgenetic hair loss and other conditions. But if 1 in 1,000 people have LPP, you can imagine in a country with 350 million people, you're going to have a lot of people with LPP. And so these are really important numbers because once you have numbers, you can go to granting agencies, funding agencies, and say, hey, look at how common this is. If you've just given $400 million to this disease that affects 1 in 20,000 people. Maybe you should give us some money that affects 1 in 1,000 people. And so it gives credibility to studies that are done in terms of how common it affects people. LPP affects different racial groups differently. LPP in individuals that have white background, maybe 1 in 1,000, and as skin color darkens, the chances are less. And so maybe 1 in 4,000 LPP in Black individuals, 1 in 5,000 in Hispanic, 1 in 11,000 in Asian individuals. So really helpful information. We're getting numbers. We need numbers, and those studies are coming to be now. Let's talk about Plaquenil, hydroxychloroquine. A nice study this year suggested that if you're on this for 15 years, your chances of a serious eye problem is about 1%. What we used to say 5 years ago was if you're on this drug for 15 years, your chance of an eye problem is probably 20%. That's a pretty high number. 1 in 5 of your patients are going to have an eye problem. This number says 1 in 100 of your patients, and it may even be less. So let's take a look at this. This is reassuring data. Hydroxychloroquine, Plaquenil, is used for LPP, sometimes for FFA. But damaging to the back of the eye or the retina is one of the side effects that people worry about. And very rarely it can cause permanent vision loss. Fortunately, if you get eye exams and the eye doctor sees any problem, they can tell you to stop. And most people don't go on to develop any problem. But it was this study in 2014 that kind of gave the background numbers. And this study in 2014 said, if you're on it for 1, 2, 5, 10 years, your chances of an eye problem is 2%. But if you're on this drug for more than 10 years, approaching 20 years, there's a 20% chance. And that was pretty scary data. And so all doctors around the world had this number in their mind. As soon as patients are on this drug 7 years, 8 years, 9 years, let's think about getting them off, because then the chances go up too high. We don't want our patients on it 7 years, 8 years, 9 years. But this new study has changed that thinking. And what this study showed is that the risk of problems is about 1% at the doses that we should be using. And so that's really important data. And that really gives us a lot more comfort that provided we have our patients seeing eye doctors, making sure that eyes are okay, that most of our patients are not going to develop any eye problems. And in fact, what this study concluded is that most cases are mild and asymptomatic, meaning you don't have any vision changes or blurry vision. And most cases are unlikely to progress to severe eye problems. And they go on to say that under current screening recommendations, so if you stick to the right dose, loss of vision from hydroxychloroquine should be very rare. So that's really powerful information. It gives us even more comfort with this very valuable medication. And in LPP, many patients are on the drug 2 years, 3 years, 4 years. It's not very common to be on hydroxychloroquine 8 years, 9 years, 10 years, 15 years in LPP. In rheumatoid arthritis, in lupus, in other diseases, sometimes yes, but not as common in LPP. Patients are often on it 1 year, 2 years, 3 years. And so chances of eye problems are pretty low. Finally, let's talk about allergy. There's 2 really great studies telling us that, wow, if you have LPP, you might have a higher chance than your neighbor of having some kind of allergy to stuff that gets put on your scalp, shampoos, conditioners. And so this study by Steinberger was published last year, and it looked at allergies. And this is a new concept, this concept that patients with LPP and FFA may be having allergens as part of their life. And what set this all off was a very nice study by Dr. Prasad in 2020, so just 2 years ago, so really not very long ago. But what that group did is they performed patch testing on patients with LPP and FFA. And what patch testing is a procedure where pure chemicals are put on the back. This is a preservative, a fragrance, a preservative, another chemical, all these pure chemicals put on the back, and they're left there for 3 days. Then the tape is taken off, and you see if patients start developing a redness or a bump or a blister at that site. And if they do, it tells you, wow, you're allergic to the fragrance in your shampoo, or you're allergic to a preservative in your shampoo. We need to change your shampoo. And so what was discovered in this study in 2020 in 42 patients is that a significant number of patients with LPP and FFA had allergens. Preservatives were a common allergen, but fragrance was a very common allergen in LPP and FFA. 20% of the patients here had an allergen relevant to fragrances. And what was so interesting in this study is that patients who had an allergy were told, let's put you on a hypoallergenic shampoo. Let's get rid of this fragrance. Let's get rid of these preservatives. If you have a problem with them, let's get rid of them. Let's give you a hypoallergenic shampoo. And many of you know these hypoallergenic shampoos. Scene shampoo, free and clear shampoo, no nothing. There's lots of them. And what was discovered in this study is that when people avoided the allergen, many people got better. Of course, people can get better on steroid injections, hydroxychloroquine, doxycycline, tofacitinib, but some patients get better on just switching to a hypoallergenic product. That's pretty amazing. So decrease in itching, decrease in redness. And the dermatologist overseeing this, the scalp said, hey, it looks much less active. And so Steinberger came out last year with a second study. Was this first study by Dr. Prasad's group just a coincidence and a fluke? No. Dr. Steinberger's study said, this is real deal. This is really important stuff. And so they conducted another study, and what they found in 9 patients with LPP and FFA is that allergens were again present. 100% of their patients had an allergen. And they compared their data to people with just a red, itchy scalp that didn't have LPP. And what they found is that 100% of scarring alopecia patients had an allergen, and 63% of patients with dermatitis had some sort of allergen. So it was much more common in LPP. What were the allergens? Propolis, which is an antioxidant sometimes used in cosmetics. Fragrances, 16%. A preservative called MI, methyl isothiazolinone in 8% of patients, and another preservative in 8%. So preservatives and fragrance, that's what people can react to. And again, in this study by Steinberger, this second study, some people avoided their allergens. And when they did so, 2/3 of them were improved just by avoiding their allergen. That's pretty amazing. And so this second study adds to this body of data that when you see a patient with LPP and FFA, the one thing you have to be thinking about in the back of your mind is there any possibility this patient is allergic to something in their shampoo or conditioner or hairspray or hair dye or something that touches their scalp? And the answer is that many people do have these allergens. Now, we don't know yet if we should be sending everyone off for patch testing. Should everyone be doing that procedure on the back, figuring out? We don't know. But we have 2 studies now that suggest that this is a pretty relevant topic. And so if you have rashes on the back from shampoo dripping down on your back, or if you have rashes on your chest from shampoo and conditioner dripping on your chest or your face, you may be the type of patient that may want to consider this patch testing kind of procedure to search out your allergen. But more and more patients with LPP and FFA that I see, we're taking them off the beautiful fragrant shampoo that suds up and lathers up, so you have a foam ball, gigantic, and it feels wonderful and it smells amazing. Those are packed with fragrance and preservatives. And some patients, by switching their shampoo, find their scalp improves. So that's what I wanted to share with you today. This association with these medical conditions, the fact that LPP is probably 1 in 1,000 people, the fact that Plaquenil is pretty safe, and the fact that patients with LPP and FFA have this chance of being allergic to the products they're using in their day-to-day life. And that's where I'll end. I'm looking forward to your questions. Thanks again, Hatchel.
Sure, no problem. Thank you very much. Well, this was an eye-opener, especially how common the LPP was. I just could never imagine that. I was probably thinking something around 1 in 10,000 or maybe even more. Wow. This is incredible, yeah.
Yeah, it's pretty high. And I think that's really important data because I really do believe those numbers. I think that that's a pretty accurate depiction of the real number.
Yeah, it's pretty close. If it's not, yeah, it's pretty close. Okay, thanks again, Doctor. It was an amazing presentation. Thank you very much. So we'll go into the Q&A now. The first question we have is, everyone says reduce stress to improve LPP. Is there any data, experiment, medication, method which prove that stress reduction is a cure? Is there?
Well, there's certainly no data to suggest that stress reduction is a cure, but there is some data, although weak data, that suggests that intense stress can activate the immune system and activate many autoimmune diseases. And so I certainly am a believer that some patients do find that when stress is high, that LPP can become more itchy, more red, shedding can increase. We do see that phenomenon often. There's not a lot of great studies, but we know that stress activates the immune system in a variety of ways. And so there is good reason to believe there is. We need more good data to figure out how to reduce stress and what are the ways we can reduce stress for patients. And patients often ask me, what's better? Meditation or an antidepressant? Well, the answer is I don't know, because those kind of studies have not been done. But I think that, you know, what we want to be thinking about all the time is that if we can develop strategies that keep stress at the lowest possible levels, there probably is benefit. Yeah. But, you know, there's going to be people on the webinar that find that stress has no impact on their LPP. And so that's the challenge in these studies, is there's always going to be people where stress makes a big impact and stress makes very little impact. So that's just what it means to be human. That's
what we're here for, to just explore.
Yeah.
Okay, this next one is, what are some correlation and causes that have been found with LPP? There's more question on the same. What are some triggers? What are the long-time side effects, the most commonly prescribed medication for treatments?
Yeah. So triggers we don't fully understand because they're so different for everyone, but there's many. We know that some medications can trigger LPP. And as more and more medications come to market, we're finding that there's more and more examples of LPP being triggered, especially some of the cancer medications that are trying to activate the immune system to kill a cancer cell. We find that by activating the immune system, some patients are developing LPP. Yeah. And so there are some medications that do that. We see that phenomenon with some infections. And so we think that, you know, maybe some infections may activate the immune system to give LPP, but that's not really clear. There is a condition called lichen planus, which is a skin condition and a condition that affects the mouth. Mm-hmm. And so a lot of the time what researchers do is they look at all the research that's been done in lichen planus to try to understand lichen planopilaris, which we think is a cousin. And sometimes that type of approach is a good way of thinking, but sometimes it's not. But we know that lichen planus can be caused by viruses sometimes. It can be caused by medication sometimes. It can be caused by vaccination sometimes. And so all these different triggers of the immune system can trigger lichen planus, and we think they can sometimes trigger lichen planopilaris. And so there are many triggers, not just one. There are many triggers. And we think that in some patients that maybe even ultraviolet radiation could be a trigger for some patients, but not for others. As far as side effects goes, the side effects of medications really depend on the medication you're talking about. And so in LPP, we use 25 different medications. And so that's, you know, I think the fact that we use 25 medications speaks to the fact that we're not quite figured it all out yet. You know, someday, hopefully we'll be able to say we use 1 or 2 medications for LPP rather than 27, but we use topical steroids. Topical steroids are pretty safe. Sometimes they can plug up the pores and give pimples. Topical steroids can sometimes cause extra redness in the scalp if you use them too long. Initially, they cause the redness to go away, but if you use them too long, they cause redness to come out. Steroid injections are another very common treatment. Sometimes steroid injections cause indentations in the scalp.
Yes.
We call that atrophy. That's temporary, but it's a very terrifying thing to experience when you have these craters in your scalp. Very rarely a little bit of corticosteroid medication gets absorbed. Usually that has no consequence because it's such a low amount. But some women, if they're premenopausal, will find that they may miss their period on account of that slight amount of cortisone absorbed. Another common medication is tacrolimus and pimecrolimus. Sometimes these burn when they are applied to the scalp, and that's kind of uncomfortable. Hydroxychloroquine or Plaquenil is a medication, sometimes affects the eye, sometimes irritates the liver, sometimes changes your blood counts, but for the most part has pretty good safety. And the other common medication is doxycycline. And doxycycline is an antibiotic, but it reduces inflammation. And the most common side effect of doxycycline is it upsets the stomach. And so by taking it with food, we sometimes have a less upset stomach, but it can cause you to become more sensitive to the sun. So now that summer is arriving in the Northern Hemisphere, patients on doxycycline need to be extra careful in the sun because they can burn easier. Doxycycline can rarely cause headaches. And so each treatment has its own set of side effects. And so the thing that's so important when one talks about treatment is to really think carefully about the individual treatment and ask, what are the side effects? But I think the most important thing is, how common is that side effect? And I think, patients and doctors become quite fearful of certain side effects. But it's a big difference if the side effect occurs in 1 out of every 3 people, or if the side effect occurs in 1 out of every 3 million people. That's a big difference. And so I think that's really important to know not only the side effects, but how common is it?
Okay. All right. Actually, I remember about your some of the steroid shots. You did it for me about 17, 18 years ago. And it was, some of them I didn't even feel. And then I remember one day you were not there, somebody else did it. I said, oh my God, this one really hurts.
They can be painful, yeah.
Yeah, you knew exactly how to do this. Yeah. All right, let's get to the 4th question. Is it possible to have any regrowth on a scarred area? This is a lot of time comes this question up on the scarred area.
So if an area is completely scarred, meaning it's whitish in color, it looks very smooth, almost like a skating rink, the answer is probably not. But if an area is devoid of hair because it's recently fallen out, but it's not really a white, plain appearance, it's just recently lost the hair, then sometimes hair growth can occur. So it depends on how long the area has been there.
Yes.
But in general, if an area has been completely scarred over and it's white and it's been like that for 4, 5, 6 years, it's unlikely to get growth in that area because the seeds or the stem cells have been destroyed, unfortunately, by the scarring alopecia. It may be possible in some cases, if it's quiet, meaning it hasn't changed, to take a hair from another area and put it into that area, and that's called a hair transplant. So sometimes we can do a hair transplant on that particular scarred area, but generally speaking, hair growth won't occur in that scarred area.
Thank you. Okay, the next one is, at what point should someone wave the white flag and end all the medications and just left what happens had happened?
I think the answer to that is really when it feels right to you. And I would add, when it feels right to you and you feel like you've had a good discussion with your doctor. Because people go through various stages of frustration, grieving, coping, and one goes through those phases of waving the white flag, as this individual says, at various times, sometimes very early on, middle of their disease process, later on. And so I think it's that two-way discussion between you and your doctor saying, listen, in your experience, have you seen patients improve from what I have? In your experience, do you think I should continue? In your experience. So I think that kind of dialogue is really important, because many patients, at their first visit, read things online, see pictures, and it's terrifying what you see when you read and see Google, and the feeling of patients is often, it doesn't sound good. Not everyone has that story, and some patients have stories that are okay, and some patients have stories that are quite favorable. And so I think it's really that discussion. But I always say to my patients that in the end, you are the boss. And if you feel that a certain outcome is not acceptable, then it could be that for you, foregoing treatment and stopping it makes sense. But for another patient, it could be that I'm not there yet. And so I think that's really a discussion between you and your doctor. Support groups like you have, Hatcho, I think are really important. Dialoguing with other patients and saying, listen, what's your experience is really important, because it gives perspective to really what is possible, and I think helps people a lot.
Okay. Is there any harm dyeing your hair? This question comes all the time, for LPP or any other scarring alopecia.
Yeah, for most people, no. It certainly is very possible to have an allergy to a hair dye. And so I think that if one dyes their hair and they find that there's significant irritation that develops, itching and redness and burning, it's an unpleasant experience, then one may need to revisit the possibility that that hair dye is in fact causing an allergy. But that's not common. And for most people, dyeing the hair is fine. And in fact, when you actually look at all the data, there may even be, for some people, a slight benefit in soothing on account of dyeing the hair. Now, that's never been really studied, but when you actually look at all the data that is available with people that have dyed their hair, there's no data to suggest it's harmful. In fact, there's a hint of data that suggests that some people actually find that their hair and scalp feels better with hair dyeing.
All right. Does LPP or FFA not always respond to JAK inhibitors?
Absolutely. Many people do not respond to JAK inhibitors.
Really?
Absolutely. And so, most of the studies so far with JAK inhibitors have been done in patients that have very severe disease to begin with. So they've tried treatment number 1, didn't work. They tried treatment number 2, didn't work. They tried treatment number 3, didn't work. Let's try a JAK inhibitor next. So a lot of these studies are being done in patients with tough disease to begin with. So we don't have really great data on how well would a JAK inhibitor work in a patient that just shows up in clinic their very first day. We don't know, but there's a lot of patients, anywhere from 30% to maybe even 60% of patients with LPP don't get a great outcome with a JAK inhibitor.
quite a
It
bit.
seems that FFA is more responsive. It does better with JAK inhibitors than LPP, but both can respond. But absolutely, there's many patients that a JAK inhibitor is not helpful.
Thank you. Okay, another question here. If someone is breastfeeding, what treatment can they take to stop the flare?
Yeah. So the short answer is that's a question always to review with the doctor and the pharmacist. What's so important about this question is the rules have changed. And what we've learned over the last 20 years is that many medications are safer in breastfeeding than we once imagined. But when you pick up the medication package and you look at your prescription and you read the 45 pages of information, you will see almost universally not to be used in pregnancy and breastfeeding. And so anything I'm about to say, you will often see on the package leaflet, it says here not to use in breastfeeding. So why is this guy saying maybe use it, it can be used in breastfeeding? Because the rules have changed, but the packaging has not been updated. So there are a couple of really good guidelines. The American Academy of Dermatology and the American Academy of Pediatrics have put out 2 wonderful documents. And I could share them at any time with you, Hatchel. And they're free online, but they show medications that are thought to be safe in breastfeeding. And that includes, occasional use of topical steroids. That includes steroid injections. That includes minoxidil or Rogaine. That includes, a number of other medications such as hydroxychloroquine. And so the medications are there in the list for one to review. And I think that those documents are so important because those documents supersede the prior recommendations that we had years ago, whereby most medications were a no-no. Now that kind of thinking has changed, whereby many medications are okay. Not everyone, but many medications are okay.
Thank you. Why do we lose body hair since there is no inflammation, no redness or itching in those areas?
Great question. The answer is we don't know. There is often inflammation in those areas. There's no redness. When you look at the skin, there's no redness, but there's inflammation under the skin and you can't see it, but we know there's inflammation. So that's the first thing. The second thing is that we're primed to think in 2023 that the only way that a hair can be lost is if there's inflammation and then it dies. It may be more complicated than that. And it may be there's other mechanisms, including neural mechanisms with nerves talking, as well as other mechanisms that lead to scarring and lead to hairs being lost. And so it may be more complicated than simply inflammation. But when you do a biopsy of the arm in someone with FFA, you see inflammation, even though the arm doesn't look inflamed. When you do a biopsy of the eyebrow in someone with FFA, even when it really doesn't look that inflamed, sometimes you see inflammation. And so it's hiding under the skin, and the very surface layer is not inflamed, and that's why it looks pretty normal, but the inflammation is about 3 millimeters, 2 millimeters under the surface.
Great, thank you. All right, the next one is, can a biopsy show a scarring outside the vertical section like ears or back or neck, and not to be LPP? Does AGA show similar characteristic? I don't have an inflammation, it says, redness or itching.
Yeah, absolutely.
One of our members.
It's really one of my favorite questions.
Wow.
Because androgenetic hair loss shows scarring, shows fibrosis. And so many people I see in clinic who have a piece of paper that says, I have fibrosis around my hair follicle, perifollicular fibrosis, and I have perifollicular inflammation. I have inflammation around my hair. And the pathologist says in the last line, consistent with lichen planopilaris. It could be, but the thing that is so important is androgenetic hair loss has fibrosis and androgenetic hair loss has inflammation. So what's the difference? Well, in scarring alopecia like lichen planopilaris, the sebaceous glands are often lost, the oil glands are often lost. And in lichen planopilaris, the actual hair cells are damaged. And so there's often death of hair cells seen on the biopsy. And we call that necrosis or lichenoid inflammation. So often these terms are present in an LPP biopsy, but not in an AGA biopsy. And so when I listen to a biopsy and it says, this was a very nicely conducted biopsy, the biopsy shows perifollicular fibrosis and perifollicular inflammation, my feeling is, okay, keep reading, because that can be anything. That could be androgenetic hair loss, that could be LPP. Let me hear the next pieces of clues. And sometimes we don't have the next pieces of clues. And so I'll have to say to the pathologist, you know, dear pathologist, can you please comment on the oil glands? Were they there? Were they destroyed? And dear pathologist, can you please comment on inflammation and death of hair cells and necrosis and all these other terms? And sometimes that's where we get the answer. But this is a really great question because we do see scarring or fibrosis in other hair conditions, not just LPP and not just scarring alopecia.
Wonderful. Thank you, Doctor. Thanks. All right, the next one is there any new drugs to treat LPP that have not been used yet and without any side effect, technically?
Yeah. So there's never a medication without side effects.
Yes.
And the reason is that everything has side effects. You know, water has side effects. Everything has side effects. So that's an easy answer. But we don't have any, we have new medications that are being studied, including the JAK inhibitors, the topical JAK inhibitors. And so the way our field works is that hair specialists are constantly on patrol looking at what's happening in the psoriasis world, what's happening in other skin autoimmune diseases, what's happening in rheumatoid arthritis field, what's happening in the other autoimmune fields, inflammatory bowel disease, multiple sclerosis, diabetes, what's happening in all these other fields, and what can we borrow? And so we're learning a lot from that. And so there's a lot of new medications that are being studied in psoriasis, a lot of new medications that are being studied in rheumatoid arthritis and all these other autoimmune diseases. And those are being studied in lichen planopilaris and FFA. And so we call those off-label indications. But there's certainly going to be a lot of new medications that we're going to be hearing about because many fields of medicine are just expanding so rapidly with treatment options. And so lots of medications to come. And you're absolutely right. We want medications that have minimal side effects, but there's no medication that has zero side effects because even Vaseline petroleum jelly has side effects. And so,
just find out lately, yes. Yeah. Okay. So the next one here, it says, how can we know truly the difference between LPP and traction from a biopsy reading? I think you sort of answered that a little bit.
Yeah, so a good pathologist can really help with that. Traction alopecia often sees certain changes in the biopsies, the way pigment is released in the biopsy. And there are very specific features that can often be seen in traction alopecia compared to LPP or CCCA. And so there are differences. Not always. Sometimes there can be some pretty subtle changes and they can look similar, but often a good pathologist can differentiate the two.
Thank you. Well, thoughts on cyclosporin, most doctors won't prescribe due to the risk. Is this something that can be taken long-term? Are the long-term effects as detrimental as made out of to be?
Really can be.
Detrimental as made out to be.
Yeah. So cyclosporin is an immunosuppressive drug. It's a very powerful immunosuppressive drug. It's used in heart transplants, liver transplants, kidney transplant patients. We don't give heart transplant patients hydroxychloroquine because it's not strong enough. We don't give heart transplant patients doxycycline because it's not strong enough. So cyclosporin is a really strong drug. But absolutely, after 1 year, we start worrying about a lot of things. We start worrying about damage to the kidney. We start worrying about changes in blood pressure and the immunosuppression that comes leading to an increased risk of cancer. Skin cancer especially, but possibly others as well. And it's significant. And so as soon as a person starts cyclosporin, the day one, we have an imaginary clock ticking, and we ask ourselves constantly, when are we going to get the patient off? From the day they start, I'm asking, when are we going to get the patient off? With other medications, I don't have that same worry. Of course, I want patients off a medication as soon as possible if they don't need it. Cyclosporin is so potent that it needs that. But it can be beneficial. It is a medication that comes with a lot of side effects. Not everyone gets those side effects, but it changes blood pressure, can damage the kidney, can change electrolytes, can change inflammation in the gums, can cause headaches. So it is a serious medication. And so that's why we put it a little lower down on the list. But it is an option if a person's not getting better with standard treatments. It absolutely is an option.
Well, actually, I remember when you were at Sunnybrook, Dr. Scott Walsh prescribed to me. And on I think it was the third day, it was a terrible side effect. So I had to call him and stop right away. So yeah. I don't think it's for everyone.
It's not.
Yeah. All right, the next one here. Zyrtec versus Claritin. Seems Claritin has less side effect, obviously, and is not addictive versus Zyrtec. Yet, does Zyrtec do something different?
So we don't know for sure because a lot of the studies have been done with cetirizine or Zyrtec or Reactin in Canada. As far as the addictive properties of these, that's a little controversial. And the other thing that's so important is the dose. And so a high dose of Zyrtec is going to have a lot different side effects than a low dose of Claritin and vice versa. So speaking about the dose is really, really important. But most studies have been done with the Zyrtec. My experience with patients is that all of the antihistamines seem to have some sort of a benefit. And we don't really know which one is the best. But we often go back to the original studies with cetirizine. And that's why we often start Zyrtec or Reactin. But I don't think there's a huge difference that we're aware of between the various antihistamines.
Great, thank you. All right. Do you believe, Dr. Donovan, a once weekly dose of 6 milligram rapamycin, is it? Those commonly used in anti-whining protocol would be effective in treating LPP?
I think it would for some patients. I think any medication that potentially tells a lymphocyte or an immune cell to be quiet can help. The studies of rapamycin are emerging, and it's an area that people are very interested in. Certainly other fields of medicine are very familiar with this drug. We don't have great studies in LPP yet to know, but the short answer is that absolutely it's going to help some people, whether that's a low number or a high number, we don't know, but it absolutely will help some proportion of people.
Okay, great. All right, the next one. If someone LPP is currently burned out and they are not on any treatment for at least a year, what are some things that can cause LPP to return, and what can be done to prevent it? This is quite a common question we have in the group. Yeah.
So a number of things can cause it to return. Intense stress can cause it to return. Injury can cause it to return. Vaccination sometimes can cause it to return. So all of the things that you can imagine that just activate the immune system can sometimes cause it to return. Fortunately, it doesn't happen to everyone, but we do see those phenomena all the time. And infection would be the other category. With various types of infections, it can return. But it varies for many people, but the one thing, the trauma is a very important concept, and that is that injury to the scalp from surgery, from something hitting the scalp, can often induce LPP to form in patients that have quiet disease. And that's why for some people, we worry about hair transplants. Is the trauma of a hair transplant going to be a good thing? Or is the trauma from a hair transplant actually going to activate disease? And so we really want to make sure it's burnt out before patients go for surgery. But there's many factors that cause it to reactivate.
Now, I know you mentioned about the vaccination in here. I don't know if you mean the COVID vaccine, because we have a little bit of a problem in our group to discuss this because of the Facebook community standards. So we can't really talk too much about it because they're trying to get rid of the people. Even I know some of the groups have been closed because of this discussion, the COVID vaccination discussion. So that's why I try not to encourage people to talk about vaccine, but since we're here now, we can maybe talk.
It's really any vaccine.
Any vaccine.
Any vaccine for a vast majority of people has no impact on LPP. But there are some patients whereby the vaccine activates the immune system, and patients find their LPP is a little bit worse. And so we know some vaccines are quite immunogenic and can activate autoimmune disease in patients that have it. And so it's always a discussion with one's doctor about risks and benefits, whether it's a COVID vaccine or a shingles vaccine or a hepatitis vaccine, flu vaccine, yellow fever vaccine, if you're going to other parts of the world. These are really important questions. And the answer is that anything that wakes up the immune system comes with a very, very, very small chance that LPP will also wake up. And so I think one just has to be aware of that and balance the risks. And for some people, hey, the benefits of doing this way outweigh the risks. And so it's a very easy decision. But when I say vaccine, it's really many different types of vaccines.
Yes. Okay. All right. Does LPP cause thin skin all over the body, and will a CO2 laser help even skin tone?
LPP doesn't usually cause thin skin all over the body. And so if that phenomenon is happening, one should check to see what exactly might be the reason for that. But LPP is not a common cause of that phenomenon.
Okay. Okay, this person says, I have both AGA and LPP. It seems spironolactone is generally given for AGA. Leukotriene, finasteride is generally given for LPP. It is my understanding that both medications are anti-androgens, and I know Dr. Donovan has an article comparing both medication. Does he ever put his patients on both medications at the same time, or is that an overkill?
Yeah, that's a great question. So spironolactone and finasteride are both anti-androgens. In women, spironolactone is used and finasteride can be used, provided pregnancy is not a consideration. In men, we don't use spironolactone, but we use finasteride and dutasteride. And so the answer is sometimes we do use both. They are two anti-androgens that work very differently. And so sometimes a patient is on spironolactone and they're doing okay, but we're not feeling we're getting the response that we want. And we make a decision. Do we go on minoxidil or oral minoxidil or laser or PRP, or do we add another anti-androgen? And sometimes the decision is made that we add another anti-androgen. And so sometimes we do use both finasteride and spironolactone. And so it increases the risk that someone will feel tired, or increases the risk that someone may feel down or depressed or have weight gain. So those are the anti-androgen kind of side effects. But fortunately, many people do great on both. And it's a really important discussion. Hey, doc, is this overkill? Sometimes it is, but we do use them together sometimes.
All right. So what is your opinion on Redensyl? Redensyl, is it? Redensyl and its effectiveness on hair regrowth. Redensyl. Have you heard this or no?
Redensyl. I don't know what Redensyl is.
Okay. All right. Let's move to the next one.
It may have a generic name, but I don't know what Redensyl is.
Maybe.
It hasn't certainly been well studied in LPP and hair growth, and so it's not something that I've ever prescribed in the thousands and thousands of patients that I see.
I think it's maybe over the counter. Maybe I'm not sure. Maybe.
Yep. Never used it.
Okay. Is it common to find LPP and FFA in the same patient? And is there anything different in the way you might treat patients with both conditions?
Yeah, so it's not uncommon. Of course, the two often are more likely together in a female than in a male. But 25% of people, 25% of women with FFA have LPP back here, further back.
I see.
And the answer is we do treat them slightly differently. When I see a patient with FFA, the two treatments that I'm thinking, is it possible for my patient to be prescribed this, is finasteride or dutasteride and isotretinoin. And those are key decisions in FFA. Yes, we use hydroxychloroquine. Yes, we use doxycycline. Yes, we use steroid injections, topical steroids, Elidil, pimecrolimus, absolutely. But the key decision is, can we use finasteride and dutasteride and isotretinoin? Because those are the most effective treatments for FFA in the year 2023. Whereas when I see a patient with LPP, it's a little bit different. Those treatments are not as front and center as being the most effective. And so it's nice to be on a treatment that helps both. But when I see a patient with FFA, those are the decisions I'm trying to make. And when I see patients with LPP, things like topical steroids, steroid injections, hydroxychloroquine, oral cetirizine or Zyrtec, doxycycline, these are really very, very important. So they differ very slightly from the standard FFA treatments. And so the answer is that there are subtle differences between the two, but very slightly. But the treatments that help FFA will help LPP somewhat, and the treatments for LPP will help FFA. It's just that it seems for some reason that finasteride, dutasteride, and isotretinoin are the most effective treatments for FFA.
All right. Just one of the members want to ask if it can involve tiny pustules on trunk and limbs. She has a skin condition no dermatologist can diagnose. She's wondering if it could relate it to LPP.
It really depends on what those look like.
Yeah.
So it's hard to say from a description. We certainly see facial papules in FFA, and we know that the small hair follicles are inflamed. Now, when it comes to the body, there are a few inflammatory bumpy conditions like keratosis pilaris, where a person gets little red bumps on their sides of their arms or on their legs or on the abdomen. So that can be related, and that's called keratosis pilaris. But the wonderful thing about dermatology is there's another 842 bumpy skin conditions that occur.
Yeah.
It's this incredible broad field of medicine where there's so many different diseases and conditions. So it's hard to say with that description, but I would encourage you to see your dermatologist. A skin biopsy can always be done if there's any uncertainty, but it's certainly not a common presentation other than that keratosis pilaris condition.
Great, thank you. So the next one is, I'm an oral minoxidil, and it's the only thing that appears to work so far. Does oral minoxidil deplete production of collagen? Do I have to choose between my hair and my skin?
We don't have any good data yet to support that. I know it's very common. Many patients worry about it. We don't have any great studies to back that up one way or the other, that topical oral minoxidil depletes collagen. And so we need good data. And there's never been a good study that backs it up one way or the other. So the short answer is we really don't know yet.
All right, we got a few more questions. Are we okay with time or another maybe 5-10 minutes?
Absolutely, I'm okay.
Okay, great. Thank you. What does doctor think about Zoriv topical as a treatment for LPP?
Yeah, I think that all of these topical anti-inflammatories, whether it's a topical JAK inhibitor, can be very helpful. The thing that's really important with topicals is what is it made out of in terms of a cream, a lotion, an ointment. So some patients find putting ointments in the scalp very unaesthetic or aesthetically displeasing to be putting the goopy ointments in the scalp. And we see that with many products, including topical ruxolitinib, including a topical tacrolimus, Protopic. And on account of that, many people are asking their compounding pharmacy to make up something more runny or lotiony that can go into the scalp easier. But the short answer is that all these topical anti-inflammatories, do something positive. The challenge is, can the patient use it? Not just one day, but 10 days and 20 days and 500 days. Do they feel like they can integrate this into their routine? Or do they feel like, when they go to work or they go throughout their day, that they just feel like everything's sticking to their scalp? And are they uncomfortable with the way things look? And so, yes, these products work. They're great options. But when it comes to the hair, some people don't like ointments very much.
I see. Okay. All right. Is there any correlation between LPP and tinnitus?
Great question. And the answer is we don't know. That's the short answer.
Okay.
25 or more % of people over 50 or 60 are going to have tinnitus. So it's a super common condition in the world. So this is this buzzing and ringing in the ears when there's really no sound that explains why I'm getting buzzing and ringing.
Actually, this was my question. So
great. And so, we know that, if you have 3,000 LPP members, that, 300 or 400 or 600 are going to have tinnitus at some point in their life. And so one would think by hearing that, wow, there must be some, look at all the people with tinnitus, there must be some relationship. But when you look at people who, live in the state of Missouri, or, the people that live in any place, 20% of those people have tinnitus as well. So it's a super common condition in the population, and we don't have good data in LPP. There is some reason to believe it could be possible based on the mechanisms of these conditions. We're seeing it in some other autoimmune diseases like alopecia areata, but we just don't have the data for LPP. So more studies are needed to figure that question out.
Well, my questions are done, but we have few questions from the YouTube channel. Are you okay with the time? Another few minutes?
Absolutely.
Yeah, okay. All right, let's see here now. All right. Let's see. My question is, if avoidance of various allergens is shown to reduce symptoms, then why not consider that exposure of this allergen is the cause of the onset of LPP?
Yeah, it very well may be for some people.
Mm-hmm.
It's a good thought, and it very well may be for some people. As I've said before, there are 50 types of LPP. So we have to get out of this frame of mind that there's one type of LPP. There's 50 types of LPP. There's probably 79 types of LPP. And so for some people, there is an allergen-induced LPP probably as a mechanism. It tends to be a more mild type of LPP in my experience, responds much better to topical steroid injections and simpler treatments, and is not tending to be the type of LPP that goes on to be, active scarring alopecia with severe hair loss. So there's really a lot of LPPs. And is there possibly an LPP induced by an allergen? I think so. And so it's a great question. And so, yes, the thing we know about the immune system is when the immune system gets activated first, 10 years ago, it adapts, it changes its way. And so it could develop a new method of thinking that an allergy now develops in that patient. And so the LPP was due to something different 10 years ago, but coincidentally, they've also developed an allergen. And so getting rid of that allergen helps them, but doesn't help them completely because there's other mechanisms that are fueling the immune system. And so I think there's many types of LPP that exist.
All right. Just asking if a CO2 laser is safe for LPP or FFA patients.
Yeah, that's really a great question. And I'm not comfortable with my patients with a CO2 laser with active LPP. CO2 lasers are very traumatizing to the skin. And we know that there are some patients with these types of resurfacing lasers who have had FFA activated by those types of resurfacing lasers. And so I'm certainly very concerned about a CO2 laser and lasers that are going to create a lot of massive redness and inflammation, unless the disease has been very quiet for a very long time. But with those types of lasers, I'm pretty concerned about the disease becoming active. And there's studies that back that up where patients have gone in for resurfacing of their face that no one realized they had FFA, and they've had facial, CO2 lasers and other resurfacing lasers, and they find 3, 4, 5 months later or sooner that their FFA is now being diagnosed because it's flaring. And some of these patients, when they go back and look, they realize that, oh, they actually had FFA on day 1. Nobody realized it. But what we learn from that is some of these resurfacing lasers really activate scarring alopecia.
All right. Got another one here. It says, does Dr. Donovan think there is a connection between diet and LPP?
I think there probably is. Whether it's a minor role or a major role, that's harder to say, and it's probably more a minor role. But we know that there's a very specific type of inflammation that's being driven in LPP. And we call that the inflammation associated with metabolic syndrome. So we know that LPP, there is this increased association with high cholesterol, diabetes, high blood pressure, and that's a very specific type of inflammation. And that type of inflammation, we think, could be fueled by high fat, high sugar, so-called Western diets, and maybe reduced by diets that are high in, fruits and vegetables. And so it's an area of the hair medicine world which has received almost zero attention, but certainly not an area that has received zero attention in medicine in general. And so I really like this question because it's a question that I talk about every day with patients. I don't think there's ever a day that goes by we don't discuss this. But I really do think that diet has a role, and that many patients share stories of cutting out dairy, cutting out gluten, and find that their LPP improves. Not everyone, And so this isn't a universal recommendation, because many people, if they do this, will find this did nothing. Why did I give up my wonderful gluten products when this did nothing? So it doesn't help everyone. But there are many people in my practice that swear by the fact that they did this and had an improvement in their disease. So we need good studies to be done. It's hard to do these studies. It's hard to get funding for a study looking at, these questions. But I am a big believer in it, because I do see patients improve with changes in their diet. Diets rich in fruits and vegetables, the rainbow colors of reds, yellow, orange, greens, blue, all those good fruits and vegetables. Reduction in saturated fats, reduction in inflammatory food products. This does seem to have an impact for some people.
Okay, let's take two more questions if it's okay with you. Right.
That's great.
Have you commonly had patients on Plaquenil and LLLT? Has photosensitivity been a major issue for them?
No, it's never been an issue with Plaquenil and low-level laser. The low-level laser is a 650 nanometer wavelength. It's not ultraviolet radiation, and so we've never come across that where patients have had photosensitizing issues with low-level laser and other treatments that we commonly use as well, like the tetracycline families. We don't see problems in our practice.
Wonderful. Okay. Does hydrochloroxine cause lichenoid eruption?
Does hydroxychloroquine cause lichenoid eruptions?
All right.
It's many
Sounds better when you say it.
these words are so tough, some of them. The answer is it doesn't commonly, and in fact there's a whole list of medications that can cause lichenoid reactions. Spironolactone is one of them, and there's a whole lot more. Blood pressure medications are another one of them. The reality is that we don't see these commonly being triggers of lichen planopilaris. We do see them being a trigger sometimes of lichen planus in the mouth and lichen planus on the skin. Yes, but for some reason we don't see it as being triggers of lichen planopilaris often. And so fortunately, those drugs are not common culprits in the hair follicle type of lichen planus.
But I got one little small question as well here. Let me just ask that and finish this. How about a ketogenic diet?
Again, we don't have the data. We just don't know. I think these are great questions for the future that so many people would be willing to do. But of course, what's needed is good studies. And, what happens too often is that patients come in and they say, I heard you talking about this ketogenic diet, and listen, I did the ketogenic diet and my hair is way better. I also started the hydroxychloroquine and the topical steroids, and I also started the doxycycline. So I don't really know if it's those medications or the ketogenic diet, but I think it's the ketogenic diet. I just wanted to tell you that I think the ketogenic diet works. That's often how the real world works, that people aren't separating different variables, and that's what's really needed in good clinical studies. And so I'm always really excited when patients, share this kind of information with me, but too often there's other factors that are in their story that make it impossible to figure out what actually was responsible for the good outcome.
Well, thank you very much, Doctor. From your busy schedule, you gave us even more than an hour. I really thank you very much. Hopefully we'll do it again. If you have any new updates, anything.
Absolutely. I am so appreciative of this opportunity to join you and to speak with you and to join your group. And absolutely, I look forward to doing it again. You just tell me the time and date and I'll be there.
I know. We miss you in Toronto, Doctor.
Oh, thanks so much.
I miss you.
All right, take care. Have a great summer.
Thank you. Thanks a lot. Thank you, Doctor.
Right,
We'll see
care.
you again. Thanks.
Bye-bye.
Bye-bye. Bye-bye.